All right, everybody, I'm back and let's get this wrapped up. So, this next section, this last section of GI alterations, is going to cover liver disorders and the complications that can come about because of liver failure and liver dysfunction, and then also gallbladder disorders, and then just briefly pancreatic disorders at the end. So, this should not be a very long section unless I just get carried away and just keep talking and talking and talking, which I suspect sometimes I do, but you never know. Actually, you guys would know. Okay, so anyway, let's talk liver disorders. So if you remember from our lecture concerning what the liver does normally, the list can be at least a dozen things that the liver will do. And one of the first problems that we have listed on here is portal hypertension. And this is hypertension in the portal vein. Remember, the portal vein is the vein that collects all of that nutrient-rich blood from the GI tract and then brings that blood into the liver for further processing. And if there is high blood pressure within the portal venous system, then that's going to cause complications for sure. So what can cause portal hypertension? Well, thrombosis, or even liver inflammation, or liver cirrhosis that we'll look at in a few minutes, or even hepatitis that could kind of go along with liver inflammation. Those conditions here, these examples, would lead to what we would term intrahepatic portal hypertension, meaning that the problem is originating from inside the liver somewhere, and that's causing a backup of that portal venous blood flow and pressure. Or we could have post-hepatic portal hypertension, meaning that there's a problem with the hepatic vein. This is the vein that drains the liver and sends that blood on into the inferior vena cava. So if there's a thrombosis there, blocking the flow of venous blood exiting the liver, that would be a post-hepatic portal hypertension. Or even right-sided heart failure. If you want to review the mechanisms behind that in your mind, right-sided heart failure is going to lead to peripheral edema as well as increased venous blood pressure. And if it's severe enough, that can cause a post-hepatic portal hypertension. So what are the consequences of having hypertension in that portal vein? Well, one of the worst ones is varices. And varices are engorged veins. They're like varicose veins and are just evidence of increased pressure in those veins. So a backup of venous blood can lead to these varices forming anywhere along the GI tract. Where varices show up that are most dangerous would be in the esophagus, lower esophageal varices, or gastric varices, or even rectal varices, which sometimes are called hemorrhoids. And then splenomegaly can occur from portal hypertension as well because of increased venous blood pressure backing up into the spleen. And that can cause the spleen to take on more pressure and more venous blood, enlarging the spleen. Ascites can develop because of portal hypertension. And basically what ascites is fluid accumulation in the peritoneal cavity. And in this case is caused by increased capillary hydrostatic pressure because of portal hypertension. So the pressure within those veins is just too high, and that's a filtration favoring force. So fluid is going to filter out of the vein and out of the veins and accumulate in the peritoneal cavity. And then finally, a pretty major complication from portal hypertension, but also from chronic liver disease, is hepatic encephalopathy. So hepatic meaning liver, and then encephalopathy. That means that there's a pathology in the head. So this is a neuropsychiatric syndrome problem that's caused by a problematic liver. And what's going on with this is as the liver is failing to do its job, one of the main jobs of the liver is to detoxify ammonia into urea. And if the liver is unable to do that, then we've got ammonia buildup, ammonia in excess in the blood, and ammonia is a neurotoxin. So nerves are wimpy when it comes to exposure to ammonia, and if the liver is not detoxifying ammonia adequately, then neurons are going to start reacting to that ammonia, creating this neuropsychiatric syndrome that we call hepatic encephalopathy. So let's look at what's going on with portal hypertension and specifically varices that develop. So here's our portal vein right here. We've got part of the liver cut away just so that we can see these other veins. But this drawing is great because it's showing that veins that are draining blood from the spleen ultimately go into the portal vein. Veins that are draining the rectum ultimately draining into the portal vein. Veins that are draining the intestines, the stomach, the lower esophagus, all of that venous blood gets drained into the portal vein and then metabolized by the liver. So if there's something that's causing portal hypertension, then the blood pressure within this portal vein increases. And so then that will cause an increase in pressure and a backup of volume of venous blood in all of these regions. And so this endoscopic view here, we're looking down somebody's esophagus again, and we can see these esophageal varices. And these varices are basically varicose veins in the esophagus. So normally we don't see these veins protruding into the lumen of the esophagus. So what do you think is one of the major problems with esophageal varices? What does that put somebody at risk for? Well, here's my favorite scenario to think about. Let's say somebody has portal hypertension. Maybe they've got liver cirrhosis or liver failure, whatever, but they've got evidence of esophageal varices now. And they're not thinking very well about it and decide to eat a bag of Doritos and swallow some of those Doritos before fully chewing them up very well. So there's some sharp objects going down the esophagus. And these are high pressure distended veins. All it's going to take is just a simple nick from one of those Doritos to open up one of these varices, and then we've got high pressure venous blood hemorrhaging into the esophagus. And this can actually, that scenario can actually lead to somebody hemorrhaging out and dying because of loss of blood. This is a really good picture illustrating ascites. So a few things that I want to point out in this picture. Remember, ascites is the accumulation of fluid in the peritoneal cavity. So that's definitely what's going on here. This is a guy, so there's no chance that he's pregnant here. So nothing to try and distract you from that. Also notice he's laying on his back, and look how protuberant his abdomen is still. So if he were to stand up, his abdomen would protrude forwards even more. So he has a lot of volume of fluid in his peritoneal and abdominal cavity. Also, notice these veins that are evident, these subdermal veins. We call these veins caput medusae because they kind of look like the snakes on Medusa's head, I guess. I don't know. I didn't name it. But the presence of these veins is evidence of portal hypertension. And so the book doesn't tell us what is going on with this individual, but I would suspect either he has liver cirrhosis or liver cancer of some sort that's caused this portal hypertension, and evidence of portal hypertension seen as ascites, these caput medusae veins, and then we would definitely want to look for other varices maybe in the esophagus or rectal area. So what do we do for folks with ascites like this? Can we put them on a diuretic? Well, you could, but that's not really going to help because the fluid is already outside of the vascular space. So what we do is what we call a paracentesis, where you stick in a needle in that cavity and basically aspirate or drain out all of that extra fluid. And more often than not, people with ascites feel so much better after a paracentesis because all of that pressure now is gone. So it's not causing the fluid buildup isn't compressing their intestines anymore. It's not compressing their liver up against their diaphragm, restricting their ability to breathe, and so on. All right, so let's return back to hepatic encephalopathy for just a few moments. And remember, this is a neuropsychiatric disorder that's caused by the accumulation of ammonia because the liver is unable to detoxify that ammonia into its non-toxic form as urea. So this can develop rapidly with a sudden onset hepatitis, or most of the time this will develop slowly as a consequence of chronic liver disease and liver failure. So ammonia is a byproduct from protein metabolism. So if you're alive and moving your body around, your body is creating ammonia as a byproduct of that. But if the liver is healthy, no problem. The liver just detoxifies it into urea, and then the kidneys will excrete that out. But if the liver is diseased or failing, then that does become a problem, because ammonia then doesn't really get detoxified and it builds up in the blood, and then it starts irritating and damaging neurons. All right, let's revisit jaundice just one more time. I feel like we talked about jaundice all the time recently. But most of this should be review. So bilirubin is what's causing jaundice, so it's the buildup of bilirubin. So if you need to review where bilirubin is coming from, I recommend that you look at red blood cell metabolism and recycling. And it's that bilirubin that causes the yellow color of the sclera in the skin in our jaundice cases. So we've got different types of jaundice listed here. Obstructive jaundice, and subcategories: post-hepatic obstruction and intrahepatic obstruction. So post-hepatic obstruction, we're thinking of the flow of bile from the liver. So if there's an obstruction in the bile duct, maybe there's a gallstone that's obstructing that, or something else is impeding the flow of bile, that would be a post-hepatic obstruction. And so the liver will continue to form bile, but it's not moving anywhere. And so then bile basically spills into the blood, and that gives us the characteristic jaundice appearance. So that would be one example of obstructive jaundice. Intrahepatic obstruction, that would be if the hepatocytes of the liver are unable to metabolize bilirubin anymore and incorporate it into bile. And so then bilirubin doesn't get metabolized, and so it will just accumulate in the blood, and we start seeing signs and symptoms of jaundice. So that would be an example of intrahepatic. Hemolytic jaundice is a little bit different here. That's also known as prehepatic jaundice. So if there's excessive amounts of red blood cell destruction, then we have an excessive amount of bilirubin to metabolize because of that. And so that can cause jaundice while the bilirubin gets kind of mopped up by the liver. So here's the flow chart here. We've got hepatobiliary mechanisms. So intrahepatic obstruction, like if there's hepatocytes that are failing, like in liver failure and so on, or extrahepatic obstruction, that would be like a gallstone in the bile duct. And so you can follow these processes. Over here on the right, hematologic mechanisms would be like hemolytic jaundice, where there's just too much breakdown of red blood cells. Liver can't metabolize all that bilirubin, and so some of it remains in the blood, and we see jaundice for a little while. Okay, let's transition into the viral hepatitis cases. So if you just see the word hepatitis, that simply means inflammation of the liver. So more specifically, medically speaking, viral hepatitis is inflammation of the liver that's caused by a specific group of viruses. And we know these viruses as hepatitis viruses. So these viral illnesses can present as systemic diseases that can cause either acute inflammation of the liver, acute hepatitis, or chronic hepatitis. So let's look at some of these in particular. So hepatitis A, the hepatitis A virus, used to be known as infectious hepatitis, but that's an old term. All the hepatitis viruses are infectious. The thing to know about hepatitis A is that it's self-limiting. We don't have a chronic version of hepatitis A that we'll look at in a second. I've just discovered I'm jumping ahead. And then hepatitis B. We're going to look at hepatitis B, used to be known as serum hepatitis, and then hepatitis C, D, E, and G. So let's look at Hep A first. So Hep A, self-limiting, transmitted by fecal oral route. So swimming or drinking in water that's contaminated with fecal matter or material, and it gets in your mouth, then that's how Hep A is transmitted. Or eating food that was prepared by somebody with poor sanitary habits, that can transmit hepatitis A as well. So crowded, unsanitary conditions, food and water contamination. But like I said, this is acute hepatitis. There's no chronic version of Hep A that I'm aware of, and self-limiting. So people feel pretty bad for a couple weeks, but then they get better. Hepatitis B, on the other hand, is transmitted through body fluids. So that's why it used to be called serum hepatitis. And as far as healthcare workers go, getting contacted with another person who has hepatitis B, contact with their blood, their body fluids, or even a contaminated needle, that's how Hep B is spread. We can also see maternal transmission. If the mom is infected during the third trimester, that virus can then infect that new baby. Hep B, it can cause chronic hepatitis. Doesn't always, but it can. And so that's one of the reasons why the Hep B vaccine has been developed, is to try to avoid any exposure or any I guess I'll just say exposure here. Try to limit the effects of exposure, especially in our healthcare workers. So that's why the Hep B vaccine is required for nursing students and medical students and so on, because we're going to be interacting with people who do have hepatitis B, and also interacting with a lot of body fluids and blood. And sometimes we don't know who has Hep B and who doesn't. And believe it or not, needle sticks still happen, and so that's always a risk. Hepatitis C, next up, is also a type of hepatitis that can go chronic. And if we do have chronic Hep C or chronic Hep B, we're starting to have therapies that can resolve that infection, but they're not 100% effective at this point. So we're still kind of getting to that point. So traditionally speaking, chronic Hep C and chronic hepatitis B are lifelong diseases, but that's probably going to be changing in the next several years. So post-transfusion hepatitis used to be the main transmission route for Hep C, but now our blood donating protocols are screening for Hep C, and so we don't transmit it that way. IV drug use is probably the most common cause of hepatitis C spread, so people sharing needles. 50 to 80%. I know that's a pretty wide range, but that's what we've got. 50 to 80% of Hep C cases will result in chronic hepatitis. So then my question to you guys would be, why is it 50 to 80%? Why isn't it 100%? Or why isn't it 0%? So while you're thinking about that, I'm going to give you a few ideas. We have to take into consideration the overall health of the person who's newly infected with hepatitis C. Do they have other chronic diseases going on? Have they been living a lifestyle that's damaged their liver already? Or how strong is their immune system, and how reactive is the immune system? So all of those factors kind of go into why hepatitis C can be chronic sometimes in some people, and then be an acute hepatitis in other people. One of the biggest complications of a Hep C infection is the development of liver cirrhosis. And even worse than that would be liver cancer. So hepatitis C infection dramatically increases the risk for liver cancer, but also for chronic liver disease and cirrhosis. These other types of hepatitis D, E, and G, I'm not going to spend very much time on. Hepatitis D is unique in that it requires a co-infection of hepatitis B. So no one's going to get hepatitis D just by hepatitis D. They have to already have hepatitis B, which doesn't happen very often. But when it does, the co-infection of hepatitis D and B dramatically increases the chance of that person developing liver cancer later on. Hepatitis E, this is another fecal-oral transmission, self-limited, developing countries, crowded, unsanitary conditions, things like that. And then hepatitis G, we don't really know a whole lot about it. I'm not going to ask you any questions about Hep G. So with hepatitis, whether it's caused by a hepatitis virus or it's caused by anything else that's causing liver inflammation, if it's chronic, it can lead to pretty severe medical complications. So let's look at this. We've got liver inflammation. Let's just say this liver inflammation is caused by hepatitis C. So early on in that inflammatory process, there's going to be pain, there's going to be fever, the person's going to be fatigued, and they're just not going to be feeling very well. But because it's a chronic inflammation, that hepatitis C virus is not going away, then the trigger for this inflammation is not going to go away. So chronic inflammation. And over time, that can lead to hepatocellular necrosis or liver necrosis. And once we start losing hepatocytes, we start losing all of those functions that the liver provides. So that huge list of a dozen things that the liver does. So decreased bilirubin metabolism, decreased vitamin K absorption, decreased hormone metabolism, which can lead to things like gynecomastia and these other situations here. Decreased plasma protein production, and that can lead to a loss of oncotic pressure within the vascular space, which will cause fluid to filter out. And so ascites and edema are common with liver necrosis and liver disease because of the lack of plasma proteins. And over time, that can lead to liver failure, which can lead to hepatic encephalopathy, and then ultimately can lead to death, because if the liver is failing, all of its functions are failing, and that can lead to the demise of that person. So as the necrosis is persisting and the person may be transitioning into liver failure, fibrosis and scarring is also occurring as well. So liver necrosis, we've got hepatocellular death, and the necrotic liver tissue then gets replaced by fibrotic tissue and scar tissue. And that can lead to portal hypertension because the liver will get more rigid the more that it's fibrotic and the more that it's scarred. And a rigid liver, a really dense liver, is harder for blood to flow through. And so that's going to cause this portal hypertension, which will lead to things like esophageal varices and so on. So understanding the reasons behind these larger boxes here is going to help you understand what's going on with chronic liver inflammation leading to necrosis, which leads to fibrosis and scarring. So let's look at liver cirrhosis in particular. Irreversible inflammatory destruction, basically, that is leading to the death of hepatocytes. And so as hepatocytes die, they're being replaced by fibrotic tissue and scar tissue. And fibrotic tissue and scar tissue does not do anything other than take up space. And so liver functionality decreases dramatically the more fibrosis and scarring we see in the liver. So in a chronic disease, cirrhosis is a slow, ongoing process. It gets worse and worse, and the biliary channels within a cirrhotic liver will become obstructed. So that would be an intrahepatic obstruction, which can cause jaundice, because we're talking about the biliary channels here, and then also can cause portal hypertension, because a rigid cirrhotic liver is much harder to get blood to flow through, and it requires more pressure. So we've got types of cirrhosis listed here, and alcoholic liver cirrhosis is caused by overindulgence, chronic alcoholism, and that ethyl alcohol oxidizes within the liver, and that's what ultimately damages hepatocytes over time. So alcoholic liver cirrhosis doesn't happen overnight. This happens because of years and years and years of alcoholism. Biliary cirrhosis, it's where the fibrosis and scarring starts in the bile ducts. And then fatty liver disease occurs when there's fat tissue or fat cells that are building up within the liver space itself. So this can be related to dietary problems as well. So NASH, or non-alcoholic steatohepatitis. Steatohepatitis just means liver inflammation with the presence of fatty accumulations there. So here's a really good example of a cirrhotic liver. You can see that it's nodular, and if you were able to palpate this, it would be very, very hard and rigid. And a cirrhotic liver shrinks. It doesn't hold the same volume as a normal healthy liver does. And so that's one of the other reasons why we see portal hypertension with liver cirrhosis, because it's just so rigid and solid, and it's shrunken in size. So it's squeezing off those blood vessels. So we've got liver cirrhosis up here at the top, which can lead to portal hypertension, which can lead to increased capillary hydrostatic pressure, which is a filtration favoring force, and that can lead to ascites. Also, cirrhosis, we've got hepatocellular failure. So everything that hepatocytes do starts to fail. So decreased albumin synthesis, which can lead to a decreased oncotic pressure, which will lead to ascites. Also, lymphatic production will go up in liver cirrhosis, and that can lead to ascites as well. So this is just another flow chart showing us how we get ascites as a result of liver cirrhosis. All right, let's talk gallbladder problems now. So cholecystitis is one of the most common gallbladder problems, and that is basically inflammation of the gallbladder. So the itis there is telling us inflammation. Cholelithiasis would mean that there's a stone, a gallstone, that's in the gallbladder. So with gallstones, they're going to be one of two types. A cholesterol gallstone is the most common type, and is usually formed because cholesterol is being metabolized faster than the bile can release that cholesterol. So cholesterol concentration increases so much in the bile that it starts to precipitate out of that bile solution and starts to crystallize. Pigmented gallstones are less common, and these are associated with liver cirrhosis. Pigmented gallstones, they're really dark brown and sometimes even black. Cholesterol gallstones, those are the greenish yellow gallstones. So what do you think? Would these be pigmented gallstones or cholesterol-based gallstones? Hopefully you were paying attention and you can identify these as cholesterol-based gallstones. So this poor person who had this gallbladder formed all of these gallstones in their gallbladder, and if one of these stones were to move down the common bile duct, it would cause an obstruction, and that could cause that person a significant amount of pain. And that's probably what led to the removal of their gallbladder here. Anybody with this many gallstones in their gallbladder, that gallbladder needs to come out. All right, lastly, pancreatitis. So inflammation of the pancreas. And I don't really want to go into a whole lot of detail about what can trigger pancreatitis, but let's look at the consequence of pancreatitis. What can happen when the pancreas gets too inflamed, and so let's explore that a little bit. So pancreatitis is basically a result of a leakage of pancreatic enzymes into pancreatic tissue. So remember, exocrine pancreas functions as a normal exocrine organ would. So these enzymes are made by the acinar cells in the pancreas and then delivered to the duodenum by way of pancreatic ducts. So it keeps those enzymes separate from the rest of the pancreatic cells and tissue. With pancreatic inflammation or pancreatitis, that can cause injury or damage to pancreatic cells or the ducts, and then what results from that is leakage of these pancreatic enzymes. So then we've got autodigestion of the pancreas, which will cause even more inflammation, which can cause even more injury and damage, which can cause even more leakage. And so this is a cycle of events that can lead to some pretty significant pancreatic damage. We can measure pancreatic enzymes in the blood if we suspect pancreatitis. So pancreatic lipase, pancreatic amylase, we can measure those from a blood draw, and that can help us clinically to determine if there's pancreatitis going on or something else going on. Also, chronic pancreatitis, that's just chronic inflammation of the pancreas, most often caused by alcohol abuse, and the risk is still the same, that there's potential for leakage of these pancreatic enzymes causing autodigestion with this chronic form as well. All right, guys, so that's going to do it for the GI alterations. I appreciate your patience with me creating the video lectures and whatnot, and I encourage you to, I always forget to mention this in the beginning of these, but as you're going through these video lectures, write down your questions if something isn't making sense. So pause it, write down your question, and then email it to me or bring it up in class next time I see you, and that way you can get your questions answered. All right, thanks again, and I will see you next time.